The speaker for the first session is Dr. Karthic Babu Natarajan, Senior Consultant, Pain Physician and Associate Professor. He is also a visiting consultant at Karthic Hospitals. His area of interests are fluoroscopy and ultrasound-guided intervention pain management, regenerative medicine and sports medicine. Along with him, we also have Dr. Karthik Raja, Senior Consultant at Kaveri Hospital, who is heading the pain clinic at Kaveri Hospitals. His area of interest include USG-guided joint interventions, fluoroscopic spine interventions, USG-guided musculoskeletal regenerative interventions.
Good afternoon. First of all, thank you all thank you for inviting us, and nice to meet all of you. Definition-wise, you are going to see these patients who have trigeminal neuralgia, who have excruciating pain along one or two or three of the branches of the trigeminal nerve. The disease is otherwise called suicide disease. What I'm trying to say is it's extremely painful. I've seen patients come and roll on the OPD floor. These patients will make sure you don't come anywhere near the face. They protect the face with clothes. As soon as they enter your OPD, the first thing they may say is to switch off the AC. And you will get to a stage where they're not moving their mouth at all, so they're basically talking through their lips with the teeth clenched. A lot of these patients will eventually stop chewing, and they'll go to liquid diet. And very common to find a patient who has not brushed his teeth, who's not shaved his face, and trying to protect the face from the even touch or air or anything like that. So it is very painful. Initially, when these patients present, the pain is only for a fraction of a second. It could be just 1 second when the patient stops talking and it's very painful, and then they sort of pick it up after that. After a while, it becomes more chronic, and that's when it becomes more difficult to treat. So typically, trigeminal neuralgia, you're going to see in an age profile which is somewhere around 50, 60, 70 years of age. So this is a disease of the elderly population. So most commonly, you'll find trigeminals who are 60s, 70s, and 80s. And the bad thing is, progressively these patients will deteriorate. So after initial diagnosis, when your medication is actually working, after a while these patients become more and more difficult to treat. So the medication keeps going up, and then we do these injections and all sorts of stuff. So initially, they describe this pain as a shock sort of symptom. So initially it may just be for a fraction of a second, and with time, the duration increases. And after, let's say, 2 or 3 years, it can be pretty much a continuous type of pain. So sometimes we ask a few questions in terms of diagnosing facial pain. So one of the common things that we ask is, does it come in attacks? So when you say attacks, so what are the things that you keep in mind when you're treating somebody with trigeminal? Obviously, you're going to think of dental issues. Then you're going to think of facial pains. The facial pains can be trigeminal neuralgia. It could be spinopalatine neuralgia. You have atypical facial pain. You have some primary headaches, the cluster headaches, tension headaches, and migraines. This is other than the sinusitis, the pain because of refractory errors, and pain because of ear infections. So you want to keep all of this in mind. Once in a while, you will also have a patient who has a glossopharyngeal nerve neuralgia, which we call as an eagle syndrome. So sometimes patients can have elongated styloid processes which impinges on the glossopharyngeal nerve either on one side or the other side. So these patients can have a bit of pain in the neck, radiating to the back, shoulder, and to the occiput. So typically, you do see patients with trigeminal neuralgia. So there is classical and there is secondary. So classical takes majority. That's about 90% of patients have only trigeminal neuralgia. Secondary could be impingement of trigeminal nerve because of some other reason. So the secondary trigeminal neuralgias could be because of tumors, it could be multiple sclerosis, it could be Lyme's disease. So these are the common indications where you have secondary trigeminal neuralgia. So patients with oropharyngeal carcinomas where there is impingement of trigeminal nerve do present with pain because of that. So classical trigeminal neuralgia is majority. So this is somebody who has male or female patient, 60, 70, 80 years of age group with unilateral facial pain. The bilateral disease you will see more in secondary. So patients who have multiple sclerosis, tumors, they are the ones who come with bilateral disease. So bilateral disease is probably less than 2% of the total presentation. So in certain group of these patients, if you do an MRI of the brain, you're going to find a neurovascular compression. So as the trigeminal nerve exits out of the brain, as it exits out, it's basically coming from the midbrain. You have some blood vessels which are coming very close to the fifth cranial nerve root. We call it the root entry zone. So most commonly we find that the superior cervicular artery, which comes in close proximity to the trigeminal nerve itself, sometimes starts touching the nerve. So when the blood vessel, which is basically pulsating, starts touching this nerve, this starts producing ectopic foci, and this is assumed to be the reason for trigeminal pain. So most commonly we find patients who have superior cerebellar artery impinging on the trigeminal nerve itself, which causes pain. Now, initially, these patients are going to have a bit of pain and they're going to have a lot of remission. It's possible that this pain becomes worse in winter months. It's possible that if, let's say, the patient is going in a bus and the cold air is blowing on their face, it becomes worse. It's possible that the peak summer, there's no pain at all. So it's possible that they have periods of remission and relapse and remission and relapse. With the progression of the disease, they're going to have a continuous disease process. So how do they sort of present? So you're going to see patients who are having pain radiating along either V stands for fifth cranial nerve, it could be V1, V2 or V3. Now it is not necessary the pain comes along the entire nerve. So patients with V3 neuralgia can have pain only here or here or here. So only part of the nerve can also be painful. So a lot of times we do see that patients who initially come with, let's say, one nerve also have overlap of the other nerves. So it is possible that they are overlapping between V1, V2 and V3. 98% of the time I told you, strictly unilateral. One of the other things that you want to remember is trigeminal pain. There is excruciating pain, but it does not usually produce autonomic symptoms. So when I say autonomic symptoms, it's watering of the eyes, anuria, any motor weakness, so that is never there. So the facial component is not involved, the autonomic component is not involved, it's purely the sensory component that's involved, so it is just excruciating pain. Now, a lot of times the common mistake that we make is anything above the ear people tend to attribute to V2, but remember V3 goes all the way up to your temple. So it's possible that V3 neuralgia actually comes till here. A lot of times we confuse this with pain here, which could also be temporal arteritis. And we also see patients who have pain beyond the angle of the mandible. So anything below, into the neck region, is not trigeminal, that's glossopharyngeal nerve. So glossopharyngeal neuralgia is below this line here. Anything above this is trigeminal neuralgia. The commonest cancer in India is oral, throat, buccal mucosa, base of tongue cancer, because a lot of the population eat tobacco. So you'll find patients who have buccal mucosa pain, having pain in the glossopharyngeal nerve or in the cheek. So depending on where the pain is, you're going to diagnose these patients. So if you go to the anatomy, so the trigeminal nucleus itself, you're going to see that there is V1, which is ophthalmic, V2 maxillary, V3 is mandibular. So the ophthalmic comes out of the superior orbital fissure, the maxillary comes out of the foramen rotundum, mandibular comes out of the foramen ovale. Now we'll have to exploit this when we actually do the intervention or the treatment. Now if you see, the black is pure sensory. So the ophthalmic and maxillary are pure sensory nerves. The mandibular is a mixed nerve, so there is a motor component that comes with the mandibular nerve. So that supplies the muscle of mastication, which is the masseter. So it also supplies the masseter. Sometimes when we do the block, we do stimulation of the nerve to know that we are near the nerve. So we actually check for stimulation of the masseter muscle. Hopefully I'll be able to show you a video of that. So the anatomy is going to be pretty much like this. So we are going to be in a reasonably dangerous area of the brain when we do interventions to treat trigeminal. Now, you know this is the trigeminal nerve that's coming. So that is the dural sleeve there. So beyond that, the nerve is intracranial. You have CSF around here. So this anatomical structure is called the Meckel's cave. So from the Meckel's cave, you have the ganglion. And from the ganglion, you have the ophthalmic, maxillary, and the mandibular. So the zygoma is actually here. So this is the external auditory meatus. So the TM joint is here. The angle of the mandible is coming somewhere like this. So you can have neuralgia along one or multiple nerves. And the pain can be pretty much only inferior alveolar, only mental, only infraorbital, only supraorbital. Now what happens is, initial time of the disease, it's possible that they have only one nerve involvement. So one nerve involvement, we may be able to get away if we do an intervention only at the periphery. So you know, as a dental surgeon, you can block it at the ventral foramen, you can block it inferior alveolar, you can get it in the infraorbital foramen, you can get it in the supraorbital foramen. So individually, peripherally, it's possible to block these nerves by either cutting these nerves, doing thermal ablations, or doing a surgical resection. So all of this is possible. You can burn the nerve, you can crush the nerve, you can cut the nerve. All of this is possible. But as the disease progresses, a lot of times there will be overlap. So patients who are having pain in V3, we have V2, so it becomes a little bit more tricky to treat. So that's why most of the time our effort is trying to catch it at the base here, which is the trigeminal ganglion itself. So it is possible, as a dental surgeon, you can block these nerves peripherally as well. Yes, it's possible. Sometimes we do block only of the mandibular, sometimes only of the maxillary nerves. So individually blocking these nerves is possible. So just a little bit about the ophthalmic. So the ophthalmic comes out of the superior orbital fissure, so you know which area of the brain this is supplying. So the maxillary comes out through the foramen rotundum. So this is basically an area between the eye and the oral cavity. And the mandibular is a little bit below. So you're looking at the neck, the angle of the mandible coming to one side below the lower lip. So this is your area of distribution. So V1, V2, V3. So we're clear about that. So if you see how much percentage of these things are involved, you'll find that V2 is maximum involved, V3 is next, and V2 plus V3 is next. So very common to find V2 and V3 involvement in trigeminal neuralgias. So usually initial assessment of this sort of patient ideally should be done by the neurologist. We do see these patients as an initial diagnosis in pain clinics as well. So most of the time, we sort of, whenever we see facial pain, one of the things that we do is we rule out the common conditions. So the common conditions that can be easily ruled out are sinusitis. So if these patients have sinus pain, it's very easy to rule out, get your the sinus x-rays and start treatment for sinusitis. Refractory errors very common, ear infections very common, so those can be ruled out very easily. And then if you are suspecting somebody with trigeminal neuralgia, it may be a good idea that you get a MRI of the brain. Now MRI of the brain is mainly to see if you're ruling out other conditions which could be a secondary cause, and you also know if there is a neurovascular compression or not, which may give you a clue as to how you're going to treat these patients. So as much as possible, in the MRI, if you do find the superior cerebellar artery is impinging on your trigeminal ganglion, so that sort of hinges your diagnosis. Now, treatment-wise, once you have sort of diagnosed it, if you are not sure, see, I'm an anesthesiologist, you are a dental surgeon, this is exactly not our feeling. If you think there is a discrepancy with the diagnosis, I would probably not hesitate to take the neurology consult just to confirm the diagnosis. So I keep emphasizing this is multidisciplinary, so I have very little ego when it comes to taking an opinion of my colleague who belongs to a different branch. So if you're not sure, feel free to get another opinion. So the management is medical and surgical. So we'll see a little bit of both. So medical, still the drug of choice for trigeminal neuralgia is carbamazepine. So in my practice, these tablets are available as 200 milligram tablets. The normal name is tetretol or oxetol. So I go up to about 1,800 milligram in a day. So that's a neuropathic pain medicine has to go up gradually. The second group of drugs is penicillin. You also give gabapentins and pregabalins. So the most commonly used drugs for trigeminal neuralgia, the first line drugs in my practice is carbamazepine, oxcarbazine. The second line groups are pregabalin, gabapentin. Some people believe in giving muscle relaxants as well, so there's a role for giving baclofen as well in treating trigeminal neuralgia. So patients who respond to pharmacological management continue with pharmacological management. So these patients have to be reviewed once in 3 months, and depending on how good their pain is or how they are responding to the medication, you can tweak the dose and maybe add another drug. So in patients who respond to conservative management, pharmacological management is enough. So in patients who don't respond to this are the ones in which you think of doing injections or surgery. So if you see the algorithm of treatment, the ones that don't respond to conservative management, you divide them into two groups. One group, you have neurovascular compression in the MRI. In one group, you don't have neurovascular compression in the MRI. So if you see the group which has neurovascular compression, if patients are not responding to medication, have neurovascular compression, age is less than 50, these are good candidates for surgery. Patients who are not responding to medication, who still have neurovascular compression, but beyond 50 are good candidates for injections. And in the other group, the patients who don't respond, but who don't have neurovascular compression, everybody has to undergo a pain injection. You cannot do surgery if you don't have compression. So this is the rough algorithm that we follow. So if you see percutaneous injections for trigeminal, there are about 3 or 4 options. The most basic one is a glycerol injection. So we get into the foramen ovale, inject a mild neuroleptic called glycerol. So glycerol basically causes Wallerian degeneration of the trigeminal nucleus itself. So this is a good technique, very safe technique. We've been using it for so many years. And in good hands, this would give a relief of anywhere around 6 months. Okay. The next intervention that we do is a balloon compression. Then we do radiofrequency ablation. Then we also do something called neuromodulation. So the first 4 in this slide, they are all injections. So essentially, they are percutaneous procedures. Among all of this, the radiofrequency ablation is the most easily possible, and this is the one that got maximum efficacy. So this is the procedure, standard procedure of care for anybody who's not responding to conservative management. So in this group of patients, you will treat them with the radiofrequency ablation. The radiofrequency ablation in my hands work for anywhere between 2 to 5 years. So what happens is, whenever you go and do a thermal ablation of a nerve, where you can cut the nerve, you can crush the nerve, you can report the nerve. Whatever we do, it will regenerate. So the regeneration process can take anywhere between 2 to 5 years. So when we say RF ablation works for 2 to 5 years, it's essentially the time it takes for the nerve to regenerate. That. So we also have a role for stereotactic radiotherapy, so where we do gamma knife, and in select group of patients we offer them surgery. The surgery is essentially offered in younger group of patients. Okay, so how do we approach the trigeminal ganglion? So it's very difficult to get in through the superior orbital fissure. So most commonly we enter through the foramen oval, identify the foramen oval, put your needle through the cheek. The needle has to go through the foramen oval and target the ganglion here. So studies show that whenever you target the ganglion itself, where the synapse takes place, if you do an RF ablation here, the effect is for much longer than targeting individual nerves. So as much as possible, our focus is the ganglion itself. So this group of patients have failed conservative management, and you've explained to the patient that by doing this block, the pain may go away for anywhere between 2 to 5 years. And if these patients come back with the pain, you have an option of repeating these blocks. So typically this is my clinic here. So you can see the patient is supine. I've sort of fixed the head. So I do these procedures under image guidance. You can do this under CT guidance, or you can do this under C-arm guidance. So you can see here, this is my fluoroscope. So this patient is supine. I am standing here. My target is the patient's right side. So I want to target the right foramen oval here, and this is the way I place my C-arm. So essentially, I am trying to get what is called as a submental view into the patient's maxilla, targeting the foramen oval. And also notice that behind me I have a hemodynamic monitor and I have a radiographer on the other side. So as I do this procedure, the ECG, pulse ox and BP is monitored. This patient is sedated and I give good local anesthesia at the point where I enter the face. So if you see here, I've come to the other side. So this is the C-arm. So this is the patient's head end here. I've made it sterile. I'm focusing the right side of the patient's face. So my point of entry is about 3 centimeters from the angle of the mouth. So here I see, you can see me having a normal spinal needle. Most commonly we'll be doing this with a radio frequency needle. So we'll see how it looks like. So more or less the angle of entry is somewhere here. The entry and where we are going to go is decided by the C-arm. So this is the fluoroscope-guided procedure. So if you see here, I hope you're seeing this. If you can see here, so this is an X-ray of the, we are going to see a few images of this. So this is the X-ray of a patient's face. So this is the nasal cavity here, this is the oral cavity, this is the chin, this is the mandible here, the TM joint, and this is the ramus of the mandible. The orbit is here, the nasal cavity is here. So if you can see this small opening here, which is oval in shape, this is your foramen oval. Okay, so essentially you are looking at what is called as a submental view to identify. So you're going to see a few of this. If you want, you can switch off these lights here.
These two lights?
You can see?
It's okay.
Okay, so what I'm talking about is this structure here. So this is your foramen oval. So this is a patient who's supine. We are trying to focus into the submental view here, identifying the foramen oval here. So the TM joint is here, the mandibular notch is here, zygomatic arch is here, the ramus of the mandible is here, angle of the mandible is here. So this is the chin, lower teeth, upper teeth, nasal cavity, orbit. So this is my area of interest here. Can you see? This is the foramen oval. So what I've done is, I'm going to put a marker here, so I know where I'm going to enter. So the point of entry, after giving good local anesthetic, is about 3 centimeters from the angle of the mouth. So the needle gets in at an angle like this. So you can see, that's the needle getting into the foramen oval. So initially you go in with this view. Once you want to check depth, you want to check the lateral view. So this is the lateral view. So you can see the needle is coming in like that. So this is a lateral view of the skull X-ray. This is anterior, this is posterior, this is superior, this is inferior. So the needle is coming in like that and entering here. If you want me to identify each of these structures, so this is C1 vertebra, this is C2, the TM joint is here, auditory meatus is here, mastoid is here, this is the zygomatic arch, needle coming in like that. That's the pituitary fossa, clivus, deepest part of the temporal bone. So the needle is coming in to the fossa like this. Again another view, anterior, posterior, superior, inferior, auditory meatus, TM joint, needle coming in like that. So that's the tip of the needle. So roughly, when the needle gets in, so this is a radio frequency ablation. So the thermocouple goes into the needle. I told you 2 of these nerves are sensory. Most commonly we see V2 or V3. The mandibular nerve you may be able to identify by doing a motor stimulation. Let's hope it plays. So I'm doing a motor stimulation here. So when you do motor stimulation, So you're going to see pictures of the masseter. So this sort of gives you a clue that you are indeed near the nerve. So if you are in any of the other nerves, you will not get a twitch. So if you can elicit the twitch here, like this, so this is masseter contraction, so you know you are near the nerve. So it sort of confirms visually, and also it confirms by doing the stimulation. Now, if you are doing the ophthalmic or the maxillary, which are sensory nerves, we only do what is called as a sensory stimulation. When we do the stimulation, the patient is supposed to say paresthesia along the distribution. If you are doing third nerve, which is the mandibular, you also get the motor contraction. So you pretty much know where you are into, and this confirms that you are indeed near the nerve. So once you have confirmed in fluoroscope and you have done the correct stimulation, then you give a bit of local anesthetic and then do a thermal ablation of these nerves. So when I say thermal ablation, we are talking about something around 70 to 80 degrees of temperature. So these needles are insulated. The active tip, which is the last bit, is about 5 millimeters. So the actual ablation where we burn these nerves happens only in the tip, which is inside the metal's cavity. You know the location by the stimulation. So if you see, this is a procedure which I did about this week, 2 weeks ago. This is on 12th of this month. So you can see I have got into the foramen over here. So this is the submental view, and in the lateral view, so this is superior, inferior, anterior, posterior. So the needle is coming in like that. The TM joint is here. This is C1. This is mastoid. The needle tip is here. The patient's eyes are here. Maxilla is here. Teeth is here. Pituitary fossa, clivus, cretus part of temporal bone. You can faintly see the ear lobes. Pinna is here. And these ones that you see faintly are actually the nasal forms of still mass. So this is the needle getting inside here. So you confirm by doing the appropriate stimulation and do the thermal ablation at a temperature of about 65, 70, 75 degrees, essentially thermally ablating or burning these nerves. So this is radiofrequency ablation of the trigeminal ganglion. The other one where we do is, this is called a balloon compression, where we put a balloon inflated, so we basically mechanically compress these nerves and burn these nerves. Balloon compression, we cannot select each of these nerves. You have to basically do all three nerves combined. So once in a while we are very afraid of doing the ophthalmic, so you can do the balloon compression. You can see the balloon compression, you can see the balloon is inflated there. We keep it inflated for a period of about 3 to 6 minutes, so thereby compressing these nerves. So this is the option most commonly done by the neurosurgeons. So I told you percutaneous techniques, you have glycerol injection, balloon compression and RF ablation. Most commonly you will find that the relapse rate is less and the efficacy is better with the RF ablation compared to the other two procedures. Balloon compression also notorious to have motor weakness, so the patients can have masseter weakness post-injection. So we also do something which is called as peripheral nerve stimulation, where we put electrodes into wherever the patients are having pain. So this is called neuromodulation. So we put peripheral nerve stimulators around these nerves. So this is for refractory patients who don't respond to any of this. There is also an option of doing concentrated radiation. So concentrated radiation is something which is available in Chennai as gamma knife or cyber knife. So this again may be an option. So this is basically done by the radiologist, where we concentrate cobalt radiation into the trigeminal ganglion, trying to destroy it. And the last group of patients, these are younger patients with documented neurovascular compressions. We do the surgery called microvascular decompression, where we go inside, do a craniotomy. So this comes with its own mortality and morbidity. We go and separate out the compressing nerve and the blood vessel, and then do the surgery. So if you see the evidence-wise, a lot of times in elderly patients, because this is a disease of an elderly population, the percutaneous technique seems to have an advantage compared to the other techniques. So lots and lots of studies showing that in elderly population, the treatment of choice is usually not the microvascular decompression, but the percutaneous procedures. So RF ablation is sort of a standard procedure that we do. Whenever we counsel these patients, we do tell them that there is, if they have a neurovascular compression, there may be an option of doing a surgery. The surgery is indicated in younger patients. It comes with its mortality and morbidity, but if it is done successfully, it may be a lifelong relief. The RF ablation is less risky, reasonably efficacious, but there's a possibility that these patients may have repeat procedures after 3 or 4 years. So this is something that we discuss and counsel these patients, and if they are okay with it, you go ahead with it. And also after an RF ablation, other than the fact that this is a procedure that may require a repeat procedure, you also tell them that after the procedure, the patients may be numb. So you're blocking these nerves, especially immediately after the block, these patients may have facial numbness, but compared to how bad the trigeminal pain is, they don't mind the numbness. So yeah, so this is the way we compare different treatment options for trigeminal neuralgia. So essentially, I'm talking about patients who didn't respond to pharmacological management. Just a little bit about other facial conditions that we do. So we do treat once in a while temporal mandibular joint problems. So we do TM joint injections. So you can do sometimes local anesthetic injections, sometimes local and steroid shots. Sometimes we even do a PRP injection into the temporomandibular joint itself. Most commonly this is done when I'm working with my dental colleagues. We do see patients with cluster headaches. So cluster headaches, if you see, the distribution is going to be pretty much unilateral, retroorbital. So cluster headache patients usually presents like this. So these patients will have autonomic symptoms, they'll have rhinorrhea, they have watering, and so they are pretty, cluster headache is very, very, very painful. So cluster headaches, so this is the way the other headaches, so migraine is usually unilateral, migraine is associated with photophobia and nausea. Cluster headache is retroorbital, again strictly unilateral. Tension headache, which is the commonest, is spread all over the place. Sinus headache, that's the way it presents. So the other conditions, facial pains that we see is, so this is cluster headache. So cluster headache comes with autonomic symptoms. Cluster headache is almost strictly unilateral. Migraine is 60% unilateral, 40% bilateral. This is sphenopalatine neuralgia. So sphenopalatine neuralgia is more along the distribution from the base of the nose going to the occiput. The last one is atypical facial pain. So atypical facial pain can pretty much come anywhere. So that's why it's called atypical. So in this group of patients, we do a procedure which is called as a sphenopalatine ganglion block. So again, most of these procedures, if you're not sure what they're going to do, we do a diagnostic injection, see if it works, and then we do an RF ablation. So that's the sphenopalatine ganglion, which is basically hanging from the maxillary. So I know the dentist also does sphenopalatine ganglion block going through the alveolar foramen that is there, just medial to the third molar. So we approach the sphenopalatine ganglion below the zygomatic arch through the mandibular notch. So that's the sphenopalatine ganglion block there. We do a diagnostic block, so that's the lateral view of the skull. So that's the sphenopalatine foramen, so I've kept a marker there. So the needle has to get into the foramen, and then we do an RF ablation. So this is the foramen here, so this is in APP. So you can see these foramen, do this procedure under fluoroscopy guidance and do an RF ablation. The last intervention that we do for facial pain is we also do a lot of Botox into the face. This is not for cosmetic reasons, we do Botox injections for migraine. So migraine has got some positive evidence in terms of getting Botox injections. So these patients are patients who didn't respond to medication, prophylactic and therapeutic for chronic migraine. In this group of patients, we put about 150 to 200 units of botulinum toxin. They respond very well, but the only problem with Botox injections for migraine is they don't work for too long. So this is for about 3 to 4 months is what we're talking about. There are also some other specific devices that we use for patients with facial pain, with chronic migraine. So this is the device which is called as Karthic. This is a device that's called as Serena. So these are basically external neurostimulators that can be used. So this is available in India. So this is one of my patients. This is the patient's permission, getting a Karthic device. So this is something that this patient had chronic migraine. So this is a sort of external neurostimulator. So this is like giving TENS for the back. So this is for patients who have predominantly headache, facial pains. So this device is roughly about 25,000 in Chennai. And so these patients have to put on this device for a duration of, let's say, about 20 minutes each day. And a lot of these patients who are already on 5 or 6 of these drugs will come down to either one or none of the medication. Lastly, we also do infraorbital nerve blocks and supraorbital nerve blocks. So each of these nerves, the pain is more along the infraorbital nerve or supraorbital nerve, which are essentially branches of V2 and V3 respectively, can be blocked individually as well. So yeah, so this is my clinic here. This is my colleague Dr. Vanmati. So you can see that the needle is getting into the supraorbital foramen. So each of these nerves can be individually identified, and you see that she's using a 5 centimeter RF needle, which has gone into the supraorbital foramen here, and you can do a RF ablation. So essentially, I talked about a lot of percutaneous techniques which are for patients with pain who are refractory to conservative management. So probably my suggestion is don't take these procedures lightly. If they do respond to pharmacological management, that should be sufficient. If they don't, these procedures are available. Most of these procedures are done under local anesthesia plus or minus sedation. They are day-care procedures, and if these patients do get good relief and the pain do come back, you may have to repeat these procedures. So that's my take on percutaneous procedures.